Okay, so thank you for having me here this morning. Can I just have a quick show of hands who's heard of the 100,000 Genomes Project before this morning? Okay, who knows what genomics is? That's perfect. So I'm a scientist, but I'm certainly not going to try and go over your heads with this. I'm going to do a little bit of an introduction to who I am, how I've ended up here. Also, a little bit of introduction, real good basics. Turn those down a bit for you. About genomics. We'll sort of then touch on how we've got to the 100,000 Genomes Project, what actually happened in technological advancements to get there, and then show you a case study. We're actually getting our first results back from the project, and we've got a whole genome sequence result come through that is actually really supported patient care, which is what this is about, and it's just about to be published. It's come out of Oxford. And then I'm going to give you some information about the training that is available to support this workforce transformation. There's a lot of literature at the front, but the same at the back. Help yourself. I'll show you contact details at the end if you need more information to get hold of me. So as David said, I'm a clinical scientist in genetics. I've had quite a varied career going from cytogenetics, so looking at chromosomes, right across to looking at DNA, which is more what I do now. I still do service work. I still have an impact on that. I started doing a lot more training for our scientists within Oxford, but Health Education England, when they were involved in the setup of the 100,000 Genomes Project, noted that we needed to train and educate our workforce. And so I am now funded for the next, I've done 12 months, I'm into my second 12 months of supporting this workforce transformation. So I support workforce development in genomics both within our local trust here, but I also have to go out to local delivery partners, so down to Milton Keynes, Swindon, Northampton, Kettering, Reading, and try and talk to everybody within those trusts to come and sort of understand genomics. I'm also working with primary care. Yesterday I was down in Luton working for the primary care conference just to try and get primary care nurses understanding genomics. I work both across rare diseases, so genetic rare disease and cancer pathways to deliver training on the project, but also I need to promote awareness among the patients, the public and school children. I spend a huge amount of time out in schools teaching genomics, which is quite interesting because it has to be completely hands-on. A few acronyms, most people will know these of NHS England, Health Education England. GEP you'll see written around now, it's the Genomics Education Programme. The Chief Scientific Officer is the ex-director of the Clinical Genetics, Regional Genetics Labs here, Anna Casella. GMC is not General Medical Council, it does cause concern, it's actually Genomic Medicine Centre. And I'll go on to these in a bit. Hopefully people have heard of the MOOCs, which are the massive open online courses, which are a really good tool for training we use now. So, your genome, think of it as your instruction manual. DNA is really tightly packed into our chromosomes. So we've got 46 chromosomes, and it's distributed between each of those chromosomes. It's packaged so it doesn't take up too much space. So our body is made up of hundreds of thousands of cells, as we know. In the majority of our cells, we've got this nucleus. Within our nucleus is where our chromosomes sit. A cytogeneticist still looks at those chromosomes. We still analyse those chromosomes. I shall show you some in a second. Our DNA is commonly known as containing 4 letters, A, T, G, and C. And the order which they are in makes and maintains our body. So they're your instruction manual. So if we think of chromosomes as your chapters in your instruction manual, if we change anything in there, we're altering the context, understandability of your instruction manual. So if you keep that idea in your head, you'll be fine. Cytogenetics is known as an old school technique. It is starting to disappear because we need higher resolution. But we still do it. It's still whole genome screening. We look at all the parts of the chromosomes in a low resolution. And we still very much use it for leukemia patients to help diagnose, particularly with chronic myeloid leukemia. We get these stripy pattern chromosomes. You'll see some more in a second. But in order to improve the resolution for us, we can use a technique called molecular cytogenetics, or FISH. Now, when I first started in this, I can remember ringing my mum and dad and saying, oh, I'm doing some fish this week. And my dad actually thought I was going to go out to a fish tank and sit and feed fish. He was like, I thought she was doing genetics. It's one of the acronyms scientists use. It's fluorescent in situ hybridization. And what we do is literally label part of the chromosome with a fluorescent tag. We have to sit in a dark room and we visualize it. But what it does is it's a higher resolution looking at specific areas. We can look for these losses, all these extra bits of DNA within our instruction manual. These are chromosomes. These are from somebody who has chronic myeloid leukemia. They are of a poor quality. If you look at the top picture of the stripy chromosomes, those are from somebody who has been referred in for infertility, who isn't ill, and therefore the quality of the chromosomes is better. But these are also taken for a bone marrow, so we can analyse the bone marrow. And you can see at chromosome 9, if you look at the one on your right, it's got a bit of a whiter bottom. If you look at the one 22 on the right, it's a little bit smaller. And that is the classical 922 translocation that causes CML. And that is the basic diagnosis of what we do. Chromosome analysis can detect if we've moved chapters or moved bits or we've got extra chromosomes, but what it can't do is detect whether we've got smaller regions of the DNA missing. The array CGH, or array comparative genomic hybridization, is a higher resolution whole genome screen. The resolution is about 100 kb, but it still can't find our spelling mistakes, our commas missing in our instruction manual. What it can do is tell you if you're missing a chapter or missing a paragraph or two paragraphs, or if you've got an extra paragraph or an extra chapter. If we've got extra or loss of material, it is likely to cause disease in some manner, but it all depends on what genes are in there. We know we've got 3 billion letters in our genome. 3 billion are inherited from your mum and 3 billion are inherited from your dad. We know that one letter may cause a genetic disease if it's changed. This technique can't identify that. It can detect the bigger changes but not the smaller. But we know that in some diseases we now can identify the genes that cause the problems, and so we can actually sequence or look at every single letter within that gene. And it is just called gene sequencing, or you may see it Sanger sequencing. We need a precise clinical diagnosis for it. It's mainly used for rare disease work, however we can use it in cancer diagnostics, look at specific areas of the gene. It's one gene at a time. It is incredibly time-consuming within the laboratory. These are very manual techniques. And it costs about £800 a gene. So some of the complex genes, really quite expensive. For cystic fibrosis, we actually only screen parts of the gene in the first stage. When we can't find what's going on, we will then go on and sequence the whole gene. And it's just trying to limit the costs. So what became out of that was the build-up of these panel tests, and this is where we have sort of more idea of a clinical diagnosis, and we then try and build upon that. So we've got lots of genes involved. The NGS panel tests are also known as massively parallel sequencing, and it's basically you're sequencing lots of different genes all at the same time. We're looking for the spelling mistakes in these genes. We've got two particular panels that for the cancer panels that we can use. There's a myeloid panel, there's a cancer panel. But also for rare diseases, we look at retinal disorders, ataxia disorders, cardiac disorders. So there's a huge number of panels we can now use. Some of them have about 150 genes on. Well, if you think that's going to cost you about £800 to screen that 150 genes, sequencing them sequentially, £800 a gene. So it actually makes no sense. And this is the way genetics is now moving forward. From array CGH to NGS panel testing has only happened in the last 5 or 6 years. It has just gone whooshing through. Okay, technology is moving so quick, it's unbelievable. Has anyone heard of the Human Genome Project? Yeah. So this was launched in 1990 and actually was completed in 2003. And it cost $2.7 billion to do. And it was actually the first time our human genetic blueprint was completely read. And it's enabled us to discover new genes that cause disease. So that really pushed advancement of understanding forward. We've actually modified it. We've actually looked at it again. And we're now on the build of 38. So it's had 38 different versions printed. And this will continue as we get to understand it more. Originally at this time, we worked out that only 1.5% of your DNA is coding, that we understood was thought to be involved in our genes. 98.5% was known then as junk DNA, and it's just been relabeled to non-coding because it contains something. It is causing effect, but we just don't understand it. And that's why we've really started moving towards whole genome sequencing, because we can look at these regions between our genes that were really thought to be junk DNA. What we know is in those areas now is what is known as regulation elements. These are the bits that really do regulate our genes. And so if they are changed by mutations or variants in the DNA, it is causing an effect on the gene, but we just don't understand enough yet. This is just the beginning of where we need to go. The Human Genome Project paved the way for large-scale diagnostic sequencing programs. I think you can imagine the amount of companies that have jumped on this and are now providing equipment for us. And we have them. That machine there is actually a desktop stand. It would fit here, and we can sequence a whole genome. You'll see this when you see whole genome sequencing reports, the read depth, it's the number of times each region of the genome is read. Generally, it's about 25 times, up to 30 times. We need it to keep reading each fragment of our DNA so that we know it's not an artifact, that we haven't caused this by the processing that we're doing. Generally, it was going to take the Human Genome Project, it took it 13 years to do this. It's now expected by Genomics England to actually take a day per sample. It's pretty quick. It's actually coming into patient pathways. It means that we can use it as a diagnostic test. The major issue is the analysis. If you can imagine you've got 3 billion letters of your DNA, we need to go through everything, see what's in the population, so everybody's got changes in their DNA that don't cause issues. What we need to look at are the changes in the DNA that will cause issues and cause disease. So that analysis can take weeks. Once we've done the analysis, we actually then need to confirm all our findings. This is still research, and we need to confirm it in a diagnostic laboratory where it's been accredited with our government companies. So how have we got to the 100,000 Genomes Project? As I said, the Human Genome Project was completed in 2003, and it produced this reference sequence. That cost a huge amount of money. But with the whole new development of new technologies, we've driven down the cost of whole genome sequencing. And now we're looking at about $1,000 being a reality. $1,000, we're looking at about £800. So if you remember back to the single gene, we can do the same. This now has the potential to bring the real benefits to our patients, drive research, drug development, and develop a personalised medicine for our NHS and within the NHS and by the NHS. And that is the key part of the 100,000 Genomes Project. It is for NHS patients. We're the only system in the world where we've got an NHS and where we've got all the health records where we can combine with this data. So it's a really key part, and everybody across the international scope is really looking at the UK to bring this forward. The 100,000 Genomes Project was actually announced by David Cameron as a part of an Olympic legacy in 2012. He had a son who unfortunately died, and he recognised that we could diagnose these children quicker and give parents a diagnosis quicker if we used whole genome sequencing. In July 2013, Jeremy Hunt launched Genomics England. So this is the company that's been set up by the government. It's wholly owned by the Department of Health. We report in once a month back to Genomics England, who report back to the Department of Health. In 2014, in December, 11 genomic medicine centres were announced around the country, and this included the Oxford, so this was the first phase. And these genomic medicine centres are your local delivery phase for the project. We recruit the patients, we do the training, we send the samples off, and we also then have the samples back into us to confirm the findings that they get. The sequencing is done by the company Illumina. It's done in the Sanger Centre in Cambridge. It's done as a central resource so the government can keep a hold on it and the government can put the targets in on reporting times. There was a huge amount of publicity, particularly of what does this mean, what does data storage mean, is the NHS ready for this, is the NHS's IT equipment ready for this? There are all still questions that are still going around, but we're working through them. So the project aims are simply to create an ethical, transparent programme based on consent. Each patient is consented into the project. It's a lengthy process. It is informed consent that they need to completely understand the findings that could come out of it. There's optionals. They can ask for different findings to be reported back to them. But once you've got a genetic result, you can't put it back. And that genetic result will stay with you for life. And it may impact on your family. So that needs to be discussed with the patients. Bring benefits to patients and create a genomics service for the NHS. This is known as a transformational project. It is aiming to get our workforce transformed and that everybody who works for the NHS understands some amount of genomics. We're not saying we need specialists in genomics in every area. What we need is people just to know that genomics is out there and how it impacts on each profession. Enable new scientific discovery and medical insights. We'll go through this a little bit more in a minute. But what is happening is the pharmaceutical companies are now involved in the project. They've been screened. They have been going through tender processes to get involved. They can start looking at these genetic changes and how it affects our bodies and see if they can develop the drugs to target those changes. Okay? The government have also recognised that we're the leaders in this. We can stimulate the UK industry and make some money back and get some investment into the UK industries. And so genomics is at the forefront. It's not having money taken off it, it's having money put in, which is quite unusual within the current climates. So who is the project for? The participants come from either a rare disease or a cancer background. We know that 1 in 17 people actually has a rare disease. And we know that there's over 6,000 different rare diseases, which we can't possibly diagnose at the moment. 50% of people are diagnosed in their childhood. That remains that 50% don't have a diagnosis till they're older. The aim of the project is to try and recruit children and their parents, if that's possible, and compare their DNA sequences against each other and look for the differences. What the hope is because it's national, a patient in London with one genetic change that causes a particular disorder can be identified with a patient in Newcastle with the same genetic change can actually be linked up. And so what we're forming is these patient support groups. And for rare disease, that is absolutely key. We may not be able to treat the rare disease, but what we may be able to do is offer support and prognostic information and what life is going to be like for these parents. For the cancer patients, it's for newly diagnosed patients. And I'll go on to a little bit more what sort of tumours are involved. But what we're doing is taking a blood sample from the patient. So that's known as their germline. It's what you're born with, DNA. And we're comparing it against the tumour. So it's called your somatic. And by doing that, what we can try and start to look at is the genetic changes in your tumour. By doing that, the drug companies are hoping they can start targeting
the drugs into the changes in that DNA. And we've already seen it with chronic myeloid leukemia and the imatinib, inotinib and nilotinib. They've all been changed just to support the genetic changes that we see on these patients. At the end of the day, everyone is benefiting from this. It is completely free. At the moment, it is funded by the government. So for the cancer pathway, we're currently recruiting for a number of different tumours. They're being added all the time as we get the pathways sorted and the pathways sort of flowing through. At the moment, we've got ovarian, breast, lung, prostate, colorectal, renal and haematological are coming in. There's certainly a lot more we're recruiting in Oxford. We're one of the leaders in this. It's been a lot of hard work, but we are recognised for everything that we do, and we really recognise our research nurses and our nursing teams who've been recruiting these patients in. We recognise that it's a complex pathway and the amount of work it's taken to get this sorted. So, in terms of the drug work, currently we know some of the drugs are interacting with our proteins. So, very simply shown with shapes, it's exactly how some of the drug companies work. They look at the shape of our proteins that our DNA make, and it fits into the folds of it. If we've got a genetic change and we alter the shape of that protein, actually that drug may not fit, and so it won't be as effective. But if we have a drug that has changed shape to match the altered protein, then it is going to be effective. And so by looking at the genetics, the genomics, the whole genome sequencing, the family history, the clinical history of these patients, where we've got currently a broad diagnosis and it's all symptomatically driven, they can have a drug. And generally we're saying it's about 30 to 60% of patients have an effective drug. So the side effects, there's the cost of it, it's not effective, the life expectancy. What the whole thing about this project is with personalised medicine, and actually NHS England have produced this document, is if we can characterise each patient genetically, we may be able to have subclassifiers of disease, of sort of tumours, of diseases, and we can actually start tailoring the drugs to each subclassified disease. And from this, we would hope that we'd get a better response. So not only for the patient, it's better, but it's saving the NHS a huge amount of money. If anybody's interested in this, this is a really nice document that talks about personalised medicine, the way it's moving forward. It's produced by NHS England. It's actually on their website, and we've only got a couple of copies that have come out to us, but it's really, if you're interested in personalised medicine route, it is quite an interesting read. And it's not too scientific. So, just to really illustrate this, I think most people who've been involved in the project who have recruited patients want to know, at the end of the day, we're here for patients, what's the effect? So I'm just going to run through a clinical case study. This is about to be published. It is coming out of Oxford. If anybody's going to any of the talks today, you are likely to see this coming out everywhere today, because we're quite proud of it. So this was a 63-year-old male who was referred in with weight loss and hip pain. And he had a family history of breast cancer. His mum, his aunt, his sister had all had breast cancer. So the BRCA testing, the BRCA1 and 2 testing was done, which is indicative of family history of breast cancer. There was no change in his DNA, in his germline DNA, so the DNA he's born with. Blood tests were done, and it actually showed an increased PSA, increased alkaline phosphatase, and increased haemoglobin. And a CT scan was done, and it actually revealed that he'd got a primary prostate cancer and bone and pulmonary metastases. The prostate biopsy showed that he'd got adenocarcinoma with a Gleason score of 8. He underwent treatment, and he had an initial response. He had a weight gain and a performance status of 1, so it's good news. But all of a sudden, his health deteriorated. He started getting a lot more increased in pain in his right hip and his upper leg. And when they did an MRI of his spine, they found progression. He had radiotherapy, chemotherapy, but they actually took a second biopsy from his rib. And what they found was a metastatic small cell carcinoma. It was negative for the traditional markers of small cell, but positive for pound-CK and TTF1. Whole genome sequencing was done on that second rib biopsy. And what they actually found was a very large homozygous, so off both copies of his DNA, inherited from his mum and dad in effect, but in the tumour, from chromosome 13. And this included 21 genes, or non-coding RNAs, but it actually included the BRCA2 gene. As I said, there was no BRCA1 or BRCA2, which are the breast cancer sort of associated genes, changes identified in the germline. This actually illustrates what we're looking at. So, this is your normal line. This is where we've got this big loss here. And in the middle, we've got BRCA2. We know that BRCA-mutated tumours are sensitive to double-stranded break-inducing platinum-based therapy. So he had 6 cycles of chemotherapy. We know that they're sensitive to the PARP inhibitors, and they started the PARP inhibitor trial. That patient did really well. And so what we know is that we've enabled a personalised treatment with this patient. The whole genome sequencing and that second biopsy were really key to altering the treatment programme and supporting this patient. It's an example, it's the first example really coming out for us that it's going to change treatment, but that's what we're hoping for this whole genome sequencing from the project to come through. For those interested in rare diseases, we are structured by what is known as eligibility statements. We've got about 200 different disorders going in at the moment. The eligibility statements state what you need for each disorder. They're lengthy. I'm certainly not going to show you here because it would take us all day to go through. They are updated based on what is fed back from the clinical community. So if anybody's heard of Dr. Ed Blair, he is our clinical lead for rare diseases. He certainly inputs quite a lot of the time into making these changes. They're available on the Genomics England website if you're interested, which I'll put the website on, and there's leaflets down here with it on. Part of my role is workforce transformation. I work for a central team. It's incredibly long hours, as most people are in the NHS, and it's many different hats. What we've been given to work to is this different sort of structures of workforce. We've got a highly specialist workforce, which is our clinical and laboratory leads in genetics. They are expected to come out and support you in any of this work. We've got our specialist clinical workforce, our oncologists, our haematologists, our metabolic medicine, our cardiovascular medicine. We've got our general workforce, general practice, all healthcare professionals. General practice are under increasing pressure. However, they are the first port of call for most of us as patients. If they don't know what the project is or the availability of these options, they're not going to have time to sit and talk to patients, and we're not going to be able to get the flow moving. Wider awareness training, we actually need to get out to our managers, our commissioners, the patients, the public, the school children. That's my role. There is one of me. We're about to take on another 3 people to support this, to try and get out there. What we can offer as a genomic medicine team are one-to-one or small group sessions. If you've got an interest in this, or you think actually my department could benefit by more detail, we've only scooted over it today, or you want some help with some case studies or anything like that, we can come along. All you have to do is email us and say, we're really interested in supporting this, or can you come along? We've got a huge amount of online courses, which I'll talk about in a second. Health Education England are funding courses. We've got these Future Learn online MOOCs, and we've got some events we hold. So, as I said, the one-to-one groups, we can tailor to your needs. It can be completely informal, it can be 10-minute spiels, it can be for an hour long, it's whatever you need us to do. It can be whatever team you need it to be. It can be me from an overall point of view. It can be our rare disease project manager, our clinical leads, our cancer project managers. There's a huge amount of people we've got working with us can do this. The Genomics Education Programme have worked to try and get this work supported. They were set up by Health Education England. And they provide free, online, completely flexible courses that have printable certificates that we can put in CPD. Some of the courses have CPD points. And as we get through the process of the 100,000 Genomes Project, so they're adding on more courses. We're certainly adding on courses. We did a training needs assessment. Hopefully some people saw that come out from the Trust for us. What we're developing is local courses with Genomics Education Programme to support this. Down the front and at the back, there's some leaflets. There's all the details of the courses that they're running. You'll need to register on a page like this. You'll actually need to tell them what genomic medicine centre you're a part of. You're part of Oxford. That is just so they know how well I'm doing my job. I have to report in once a month to them and tell them how many people I've spoken to. The courses include down to the basics, up to the complex. Some of them you'll look at and think, I really don't need to know that. It's about how a sample's processed through the workflows. If you're not interested, don't worry about it. You know, have a look at what you think you need. The ones I would really recommend are the introductions to genomics. It's the fundamentals of genomics, its importance in patient care. For those who've got a bit of a sort of feeling for the computational side of genomics, how we look at these changes in our DNA and how we work out whether they're going to cause disease. That's a new discipline called bioinformatics. We've started training people in it. But there's a little course on it, it's an hour and a half long, and it's really quite interesting to see the background to where we're going with this work. For anybody who's interested in consenting patients into the project, we actually require you to complete this Preparing for Consent Conversation course. It gives you 2 CPD credits through the Royal College of Physicians. And as you can see, it says it complete at your own pace, 1.5 hours long, and you can. You literally can dip in and out of it. It says where you're up to, so you don't need to keep repeating it, and it's completely flexible. Health Education England obviously are running Genomics Education Programme, and they've recently done a massive online MOOC course that is completely free called the Whole Genome Sequencing, Decoding the Language of Life. For those who know Anna Casella, she is actually moderating this. She actually did it while she was still with us in the labs. There's an introductory course video on the Genomics Education Programme website, and the new course starts on the 22nd of May. And what they do is release little bits of information every week. You don't have to do it when they're released. I signed up. Due to time constraints, haven't finished it. You can dip in, but once you've signed up to it, you can just get that information when you're ready. It's stored there for as long as that course is running. Okay, so it's completely flexible. The recognition by the Genomics Education Programme is that healthcare professionals don't have 2 or 3 hours to sit down and do any kind of study in work time. These are just flexible for an hour or half an hour whenever you've got time. This is the sort of what it's looking like at the moment. It's, as it says, it's free. If you want a completion certificate, you need to pay £35. What we've done in the labs, and for those who've already done it, is just print the completed page off. You get an email to say you've completed it, print that off and put it in your CPD files. We're certainly not going to say to people you need to pay £35 for these certificates if you don't want to. The HEE Funded Courses, which gives you a little bit more information on these postcards. These are up to master's level courses. They are completely funded. We have access, I think, to about 800 individual modules at the moment. They're £1,000 a module. They are run at 10 different universities around the country. They start on introductions to genomics, introduction to bioinformatics, there's cancer programs, there's rare disease programs, there's genomic counselling programs. There's a huge range of courses available to you. There is contact time, but distance learning is there as well. There's more information on that, the Genomics Education Programme website. But if you're interested, you can apply for funding. Any NHS employee can get this funding. And it's out there to be used. If we don't use it, it's going to get swallowed up. So actually, 800 courses, that's a lot of money going at the moment. I've mentioned FutureLearn. This is the platform, the online platform that Health Education England have used. But there's a huge number of courses. If you put the keyword genomics in, there is a lot of courses there that will support you in learning about this. They're free, they're online, they're flexible, they're really interactive. They've each got a forum where you can all communicate. For the Health Education England one, we actually had a retired GP who was keen to keep up to date with what was going on in scientific advances and was really key in promoting discussion and sort of put in a few odd questions that really got discussions going. It's provided through FutureLearn, but you'll get universities such as the University of Manchester, St George's, Health Education England. It's all top universities actually promoting this material and using it, so it's a really good way of learning. A couple of the courses, so the Genomic series, The Future of Genetics and Medicine, run by St George's. They've actually done a whole series of them that if you do 3 of them, it supports you in working towards your PG, DIP or CERT in genomic medicine. As you can see, it runs for 5 weeks and it suggests a time of 2 hours per week. You certainly don't have to do that 2 hours in one go. You can do it in and out. And once that material is released, as I said, you can have it at any point. Clinical Bioinformatics and Unlocking Genomics in Healthcare is run by the University of Manchester. They actually train all our scientists. So they are the ones with the knowledge and seem to be doing a really good course on this. Has anyone been to the Genomic Café that we do? No. So, this is where we put a sign up saying free cake, free tea and coffee, and in small print genomics. People come and talk to us. People see the word genomics and are quite frightened. They think it's just really complex, but actually we're running these cafes as an informal event. If you think you've got an area, staff area, where we can come along and provide you with some tea, coffee and homemade cakes, we will do it. We will do it whatever time you want us. If it's first thing in the morning, that's fine. If it's last thing of the day, that's absolutely fine. We'll come along with posters, with people, with games to show you what genomics is. You can get a hands-on experience of what genomics actually is. You can meet the team, you can ask any question you like. If you've got a case and you don't know whether it's really applicable to be recruited to the project, bring it along, talk to one of the clinical leads with us. It is informal, relaxed setting. How to get involved with it and to take some of the courses that I've just presented. Get involved in recruitment. Identify patients. Have a look at the eligibility criteria. Have a look at your patients you're seeing. Discuss possible patients within the GMC team. Email us or ring us. We're more than happy. You can see the triangular tabletop stands. Hopefully you've seen those around the trust. Take our phone numbers off that. It comes straight into our office. We will sort out queries there and then. If you're interested in genomics, we need people to pass information on to disseminate through your departments. If you want to be one of those contacts, let us know. We're more than happy to just pass out simple information for you to disseminate, put up posters in your staff areas. But most of all and primarily, tell us what you need. If we don't know what you need, we can't help. You know, if it is a 10-minute spiel on a ward, that's absolutely fine. We'll come along and do it. Huge amount of contact details. We've got 2 different project managers. So we've got the cancer project manager, who's Maita. We've got Jane, who's our research nurse, who is an absolute block to us, particularly within training, and myself. My contact details are there, and the rare disease project manager, G Craft, is also there. I've put down the websites for Genomics Education and the 100,000 Genomes websites. There's a leaflet at the front, which is a generic one on the 100,000 Genomes. Contact details for us is on the back. But if you just search 100,000 Genomes Project, you will come up with the website for Genomics England. Just want to say a few thank yous. The Molecular Diagnostics Centre here in Oxford, obviously, for the case that's about to be published, from Helen and Anna and Lara. Jane, as I said, has been a huge amount of steering work within the Cancer Pathways, and Jude for the rare disease work. Is there any questions?